It's 8 o'clock on my computer. So good morning and thank you so much for joining us today for our kickoff of our diabetes cardio-echo tackling type 2 diabetes series. Okay, I think we have everyone.
All right, so I am going to go ahead and get us started with just a brief introduction of the structure of the Echo Clinic series. It'll be a little bit truncated today because we do have a special guest. And so I would like to welcome Mary Applegate. Dr. Applegate is a director of Ohio Department of Medicaid, and she would like to give us a few introductory remarks. Dr. Applegate, are you on?
I am. Good morning, everyone. It's really been wonderful to listen to all of you and kind of hear where you're coming from and recognize the interest that you have in just trying to do a better job. This is a wonderful learning opportunity. I think it's a modality that actually fits into our practice style where we can take an hour or two out and actually learn, present our cases, kind of harness all the academic and practical experience of the entire team across the state. So thank you so very much for your interest. I believe many of you are aware that we're one of the richest states in terms of academic and community training centers for physicians, nurses, and allied health personnel. So it sort of made me wonder, why aren't we doing better for people we take care of in the program? So why are our outcomes not better for people in the program if we are this excellent at understanding the science? So that was kind of the beginning of trying to pull all the academic centers together in a sort of collaborative. This particular ECHO builds on the work of our QI efforts with the Cardi-OH. I see Dr. Bolin here on the phone as well. So she's one of the ringleaders for that, and many of you are participating in that as well. Those are more official QI activities with data collection that are really about implementation. So I think as much as it's important to understand the content, it's important to have not just the direct application intellectually to our patients, but to figure out how to get best practice into our practice day in and day out. So I'm super excited that we have some residency programs here as well, because we've learned that before you've been in practice for 20 years, things are not cemented down yet. And so young people and changing people often give us new ideas, and melting that together with the experience of people in practice may be a really strong step forward. So I'm excited to kind of embark on this activity to see what difference this actually makes in practice. So there are a couple of things, particularly now with COVID. I think practitioners might be more isolated. It is more difficult to just curbside people. For those of you who are old enough who remember that, or who can just pick up the phone and call your colleagues and say, hey, I've got this interesting situation, can you help me think about it? So the ECHO model actually allows us to do that with a little bit of scale. The other thing that may be more apparent through a model like this is just direct attention to disparities. So if each of us just has one or two patients who aren't doing well and they happen to be from communities of color, we think it's just, one or two or three people. But when we add it together, there are striking disparities in communities of color. So I'm thinking that some of those issues will actually surface in this effort as well. Many of you may have seen Dr. Hall's book kind of outlining the very distinct differences for African Americans in terms of even how we treat hypertension and diabetes. What are we don't use the same first-line drugs, for example. So bringing that to the surface in this day and age certainly seems to be appropriate. We're particularly aware of disparities with COVID. So if you're diabetic and you get COVID, you will not do as well. And then if you add the fact that you're from a minority population, this is just not a good combination of risk factors that then may lead to poor outcomes. So we've learned a number of things so far, and strong leadership is certainly one of the things that keeps these efforts going. So hats off to all of you. We also realize that it's difficult to take time out of your day and to work this into your workflow. So all of our practice sites, thank you as well. Many of you are actually part of CPC, Comprehensive Primary Care. So we are thinking about how to pay differently and better in a more sustainable way to get to population health improvement. So we are hoping that as CPC sites in particular participate, that your diabetes scores actually look better as well. So there may be, there's alignment, but there may actually be additional synergy that helps us move forward faster. So I want to let you know how wholeheartedly we actually support this. Many of you know that I'm a MedPeds clinician, or originally from OSU in Central Ohio, but now I feel like I'm from the entire state since we have so many efforts across the state. And I'm really looking forward to participating in at least some of your sessions and learning along with you. So thank you in advance, and I'm hoping for the chance to at least address you or learn from you at intermittent periods over this effort. So thank you, all of you, and I wish you the very best as we embark on this learning journey.
Well, thank you very much, Dr. Applegate. That was a great introduction. And, you know, I really feel, you know, very excited, and I'm very lucky to be able to participate in this. We'll start off, I suppose, on just going through the, you know, the basic structure. So as you know, we've begun our introductions. We won't do a full roll call every session, but it'll be, you know, by site, and we'll have sort of similar instructions for logging on and letting us know that you're here. That will be followed by a short didactic presentation with some Q&A directly related to the didactics, and we'll try to pull in our content experts that are assigned for each of these sessions. And you can feel free to share your questions through a variety of different ways. You can just unmute your microphone. You can use the chat function at the bottom of your screen. And you can, you know, you can also use the hand raise feature if you're, you know, a more advanced Zoom user. And then following the didactic presentation, there will be a case study presentation and discussion. It does not have to be a rare bird, and you'll see an example presented by Dr. Rao today. And it's really meant to open up the conversation. With respect to diabetes, there is no recipe book per se where you have to exactly measure all the ingredients and do it the same way to get the same outcome. It's very much individualized. And so that's where this case study is really important, I think, to help us all learn and learn from each other. And then finally, we'll have a brief wrap up. It's very important that we have you complete the post-clinic survey, because it helps us understand that the content that we are providing is helpful and that it's working. So with that, I will get started on our first didactic session. So our disclosure statements from myself and the other speakers, moderators, panelists are shown on this slide. In particular, I do a lot of clinical trials, advisory activities and such, and you can see details of these on your email from Shannon earlier this week. Okay, so today we're going to discuss the standards of care in diabetes, and this is specifically coming in large part from the American Diabetes Association, which puts these comprehensive guidelines out every year, and they're by far the most comprehensive of any of the guidelines out there, although there are other professional societies that also you know, develop guidelines. Some of them are in concert or in conjunction with the American Diabetes Association. So this is not meant to state that the ADA is the only guidelines that can be used, but they will serve as a framework of sorts for today. And these are our objectives. We are going to just highlight a few of the major changes from the 2019 to the 2020 guidelines that happened this year. We are going to introduce the screening and diagnosis of type 2 diabetes And then we're going to start on a stepwise progression of the initial management, including a variety of different elements. And then we'll build on this throughout the rest of the season. Okay, so when I'm looking through all of the changes, this is a 200-page document. There's actually an abridged version for primary care. So be sure that you check that one out if you're feeling overwhelmed with the scope and size of this document, if you happen to look at it. So basically I have the changes that I wanted to highlight here color-coded, those items that are discussed elsewhere in the ECHO series. I'm just going to kind of breeze through. I do have a key change that I wanted to discuss, and some elements that we're going to discuss today. So in terms of that lifestyle, we will kind of discuss that. There were a few changes. They weren't monumental changes, but we'll discuss that in our dedicated ECHO series or ECHO event for related to lifestyle changes. We're going to talk a little bit about some small changes with diagnosis in terms of you do not necessarily have to have a separate blood draw for a confirmed diagnosis of diabetes. Another small change, but was introduced a couple of years ago by a consensus panel, is the ambulatory glucose profile. Now that we have more and more people, even with type 2 diabetes, who are on continuous glucose monitors, how do you make sense of the report? So we'll talk about that later on in this series. One of the most important key changes this year was how to approach these newer drugs, in particular the SGLT2 inhibitors and GLP-1 receptor agonists. These drugs have had ongoing clinical trial results that have really solidified our understanding of their benefits in terms of some of the cardiac and kidney complications. And the ADA is now recommending that they be used even in patients who don't have an elevated A1C, if they have some of these comorbidities. So we'll talk about that. In terms of hypoglycemia, the ADA is really emphasizing this year, the need to not just ask patients if you have hypoglycemia, but to really understand what is the extent, the severity, the frequency, and actually screen patients with the knowledge that even patients with type 2 diabetes, especially if it's long-standing or insulin requiring, can have hypoglycemia unawareness. And then finally, we're going to talk a little bit about early combination therapy. So there's some interesting studies. I would not say this is the first trial, but this was highlighted in the ADA recommendations on the use of combination therapy from diagnosis, how that might provide some benefit. And then finally, we'll talk more about insulins, and in particular, how to really use them as effectively as possible to minimize hypoglycemia and hyperglycemia. We'll talk about that a little bit later in the series. All right, so many of you understand this working in primary care because you take care of so many patients with diabetes. But just to ground us, who should we be screening? These recommendations haven't changed in quite a while. Almost all adults need to be screened, generally at the age of 45, and then a host of other risk factors, some that we don't always think about, such as whether a woman had a baby weighing over 9 pounds, some higher risk ethnicity or race and ethnicities, and features of dyslipidemia. And then the screening should be every 3 years. If there's some question and if it's abnormal but not diagnostic, then it should be repeated annually. And then how do we screen? Many of us rely upon the A1C because it's by far the most simplistic approach. However, just a little bit of a tweak in the guidelines this year. If you do happen to get a fasting glucose and an A1C and they are concordant, with the diagnosis of diabetes, then you don't have to repeat it. I think sometimes it's easy to forget, you know, if you get an A1C, especially if it's borderline, that it's generally advised for best practice to repeat it to confirm. And then we have the oral glucose tolerance test, which isn't conducted very frequently, but here's your criteria there. It is the most sensitive test, so if you really got to know, it's going to be most sensitive. That is going to be at the expense of a bit of loss of specificity. And then your fasting glucose and A1C criteria shown here. Now, in particular, if you have a random glucose over 200 and suggestive symptoms, then of course that also gives you the diagnosis. So for patients who are found to have pre-diabetes, it's definitely strongly encouraged that we try to get them into a diabetes prevention program. And you'll learn a little bit later in this series what all that program entails, but it is very detailed. It's more than just a single visit to a dietitian. It's really a comprehensive program involving health coaches, dietitians, even exercise physiologists in the original DPP program. Okay, and there are tools out there, even for patients, for high-risk groups. This is a great one that actually is you can use it in paper form, but also is available in electronic form at the ADA website. Okay, so when we have somebody who's newly diagnosed, what's the approach? Well, we want to know what should be our end game first. I think we can all agree on that. And then we can tailor the approach to what should be that goal. And I'm sure many of you have already kind of had experience in setting A1C goals. But you can see here that I don't really have a set cutoff. I'll show you another slide which does have maybe some cutoffs for guidelines. But because I honestly feel that it's a little bit different for everyone, and by the time you put in kind of all of these different inputs, you might have a slightly different goal. So keep in mind that some of these characteristics that we use to determine what should be the patient's A1C goal or glucose goals are potentially modifiable. So that means that just because the goal is 7% now doesn't mean that it'll be 7% 5 years from now, and even vice versa. So a patient who really struggles with resources and support, can't afford medications, for example, and then their situation changes where they do, they are able to afford, maybe some better medications, then, you might be able to modify your target because of the risk-benefit profile changes. And so you want to think about all these different things: hypoglycemia, how long they've had diabetes, what's their life expectancy, do we have major comorbidities? And I'm not just talking, that they have, a little bit of arthritis that keeps them from doing their marathons. If they have, more advanced cardiac complications, and then again, keeping into account some of these more patient preference and a bit capability. Okay. So this is taken directly from the American Diabetes Association guidelines, because we all like to have numbers, right? We like to have sort of a solid, a solid guidance for what should be my patient's A1C. And if you look at other guidelines, you'll see slightly different cutoffs. And I think that's just the nature of the phenomenon. Now, it's not that you can't see complications in patients who have an A1C less than 7%. It does occur. And certainly, so being mindful of if you're dealing with a 20-year-old patient versus an 80-year-old patient, there are some professional guidelines that will recommend that you do lower than 7% if it can be done safely and without a lot of treatment burden. And then what's also nice about the ADA, and they have some separate recommendations for older adults, is to really think about, and not just are you older, but what's your health status? And so again, I've seen some very, very healthy 80-year-old people. And so your management's going to be very different from, you know, maybe the 80-year-old person who has much more challenges in the way of chronic illnesses, cognitive impairment, and ability to perform activities of daily living. So this was another sort of table that is provided in the ADA guidelines to help sort of guide you. But note that even this is really more of a guidance. It's not like we have hard data that says, you know, an 80-year-old person with this level of ADLs who has an A1C of 8 is going to live any longer or not as long. So individualize until we have more data. So as stated previously, hypoglycemia is important. And not only is it important, but we also should be able to communicate what is hypoglycemia. And these are the recommendations for classification of hypoglycemia. I'm sure that many of you may not be aware, but what's most interesting is that a severe event in particular isn't necessarily what a patient might view as a severe event. It's basically, it should be defined as any event requiring external assistance from someone else because of altered mental status or because you have become physically incapacitated. So that's a severe event. Otherwise, you can stratify according to level 1 hypoglycemia, which is considered mild and it very rarely, results in severe outcomes, and more marked hypoglycemia, which is glucose less than 54. We should ask about it at every encounter. Ask patients, how low do you have to go before you feel symptoms of hypoglycemia? And how often is it occurring? What time of day is it occurring? And then treat and manage accordingly. And we'll talk about this a little bit more later on when we discuss insulin in another session. How often do we monitor? So pretty much everyone should have a glucose monitor, but it is really arguable whether a patient who is not on insulin needs to monitor on a regular basis, particularly if they are just monitoring just because that's what they're told to do. They need to be able to use the information if they're going to be monitoring, and really importantly, they need to have feedback. And in many studies, people who are not needing insulin, if they're not getting immediate feedback, on their data, whether it's, from using, apps or devices that provide that feedback or directly from their providers, their A1Cs, their glucose control overall does not benefit. So, the one exception might be patients who are on sulfonylureas, so there might be an increased risk of hypoglycemia there. And it's going to be very patient dependent. But I think pretty much everyone should at least have a glucose monitor and understand how to monitor their glucoses, particularly during changes in their lives, like illness, that can really cause abrupt changes in glucose control. Now, moving on, so patients who are on insulin, generally for basal insulin, I think this should come as no surprise. We do want patients to monitor, in particular, at least, in the morning, and usually once or twice or a couple other times per day, because in the morning, that glucose value is what's used to titrate the basal insulin. And then those patients who are needing multiple injections of insulin per day generally recommend at least 3 times a day. That's generally what Medicare will cover, but oftentimes we'll want additional times a day. It can get more and more challenging the more times we ask them to monitor. And so in this group especially, continuous glucose monitoring is a really helpful tool. And this would be most important for people who are not meeting A1C targets, who for whatever reason are not able to monitor as frequently as we need them to monitor, if their A1C is not matching what we are getting from their glucose values, and if they have hypoglycemia or difficulty with hypoglycemia. In other groups, CGM could be used. It has been demonstrated in sort of haphazard ways that it might help guide, diet and lifestyle choices, but it really has to be implemented in a very structured way and with really strong feedback. And so most of us, you know, and in most cases it's not covered by insurers. Whereas on multiple injections a day, it's generally covered, at least to some degree. Okay, so this is going to be a more detailed slide that gives us a summary of the ADA standards of care. So basically, it's still recommended to start newly diagnosed patients on metformin plus lifestyle changes. Lifestyle changes are always part of any treatment regimen. And so because it's going to be covered elsewhere, I'm not going to spend a ton of detail on it. But I do want to highlight that, yes, it is critical. And that might also include, you know, weight loss programs, weight loss surgeries, weight loss medications. So if someone has an A1C that's greater than 1.5% above target, the general rule of thumb here, at least according to this set of guidelines, is to start 2 agents. So let's start in the middle here. So if someone has atherosclerotic cardiovascular disease or chronic kidney disease, what do we do? Even if their A1C is at goal, the new guidelines really do recommend going to one of these 2 classes of agents. So if you have atherosclerotic cardiovascular disease predominantly, start a GLP-1 or an SGLT2 inhibitor. If you really look at the details of the outcomes trials, patients who've had a stroke, the GLP-1 outcomes are better. They're neutral across the board. So that would be my one caveat that I would add here. And then if a patient has a history of heart failure, could be any kind of heart failure, or any kind of nephropathy or chronic kidney disease, an SGLT2 inhibitor is preferred for those people as long as the eGFR is, you know, okay. Okay, so then if not a goal, then you can add another agent, you know, potentially one from the other class. Or from some of these other classes. So we're considering compelling indications otherwise. So drugs that cause hypoglycemia, I'm not going to go through in detail, excuse me, drugs that do not cause hypoglycemia, I've shown here for you. There are some sort of second choice agents. If you're going to use the sulfonylurea, you should use a later generation sulfonylurea. You know, if a patient really is struggling with hypoglycemia, there's some changes in insulin that you could consider if they need insulin, and we'll talk about that later in the series. If weight gain is their predominant problem, I find it hard to believe that it's not the problem for the majority of our patients. There are 2 drug classes that cause substantial weight loss, and then here in the white and red are drugs that maybe don't cause weight gain, and then other considerations like minimizing your drugs that cause hypoglycemia or TZDs. And then finally, cost is a huge issue, particularly for, I think, actually our Medicare patients more so than any of the other patients, because there aren't, you know, backup programs available for many of them. And so in that case, your sulfonylureas, your TZDs are very inexpensive. You can get NPH insulin from Walmart for $25 a vial if you're paying out of pocket. If you just joined us, would you please mute your microphone? Thank you very much. Great. Okay, and then again, so you kind of repeat the cycle. And honestly, I think most patients really have issues that want to address all of these factors. So, you know, it still can really boil down to what is the predominant factor here. And that requires some discussion. Okay, so when we're looking at the treatment classes again, I won't go through this in detail. Think about efficacy. The GLP-1 receptor agonists and insulins are about equal. You know, head-to-head studies of basal insulin and GLP-1s, similar, if not better, A1C reductions with GLP-1s. That doesn't mean that if you go to multiple injections of insulin, though, you might still get some additional benefit when used in combination. So that's something that's not really well emphasized in the guidelines here, but lots of head-to-head studies and some challenges there. Other side effects you might think about discussing with your patients, for example, with SGLT2 inhibitors, if someone's already got a really high A1C and is struggling with yeast infections, I might, try to get their A1C down first and then add the SGLT2 inhibitor so that I can be sure that they can tolerate it. Other considerations, if you're going to have a postmenopausal woman on a TZD, at least think about doing some screening for osteoporosis, as it can reduce bone density, particularly in postmenopausal women. We talked a bit about cost already. And then in terms of cardiac benefits, recall again that our two classes, SGLT2s and GLP-1s, really are the only ones that have demonstrated benefit thus far. Okay, and then this is really what I was alluding to previously. This was a randomized study that was conducted over a 5-year period to really try to tease out, do we start people on 2 drugs at once or 1 drug? So these patients had an A1C that was actually, not too bad, around 7% at diagnosis. They're randomized to vildagliptin, which is a DPP-4 inhibitor. It's not approved in the US, and metformin versus just starting metformin. And so you can see, of course, not surprisingly, that the initial treatment failure for metformin was higher because they're on 2 drugs, versus the group that was on 2 drugs here in the blue. But then they had a second phase. So if their A1C rose above 7% during this treatment period, they were then started on combination therapy. And if they failed that, then they started basal insulin. So lo and behold, after the second time, after failing treatment, when did they fail the second time? So it turns out that those people who were originally assigned to combination therapy were less likely to fail, even the second time around. So by that time, we're thinking that this might be a demonstration of something called metabolic memory. So if you start somebody aggressively early on, the argument is that you will delay progression. Okay, so, and then lastly, I won't go into detail here, but this is just, really a patient-centered glycemic management strategy in which we use shared decision-making.
All right, thank you, Kathleen, for that really helpful overview of the latest guidelines, especially the specific changes that take place. So if I was referring her to Kathleen, I'd have very specific questions for her, and Kathleen would have a very, very specific charge. But I'm going to see this lady probably every month or every couple of months, at least for the first year or so. So I've got time to do things. And in my experience, and we know this from cardiovascular risk management, if you overwhelm a patient, say, okay, I need you to quit smoking, I'm going to check your hemoglobin and say, you got your ophthalmologist appointment, you've got your lab test, I'm sending you to Dr. Dungan, I'm starting you on an SGLT2, and here's a lifestyle program, here's a referral to weight management. I gave her 9 different things. You know what? She's probably not going to come back, and she's not going to have a great encounter. So one of the tasks is prioritizing what we want to do for this patient. The other task is what would we do about her pharmacotherapy, which is clearly not even close to adequate, given her general lack of comorbidities in relatively young age. So I'm going to stop there. We've got about 6 or 7 minutes, and maybe first to see if the group has any questions for Dr. Dungan, Shannon, and we can go on to the case discussions.
Yeah, I thought I'd start off the first question. Did she express to you, or were you able to ask her what aspect of her health she wanted to focus on? And I don't know in particular related to her diabetes, since obviously you're presenting that here, but.
Yeah, so she's very focused upon diabetic control. A number of older relatives have long-standing type 2 diabetes, renal failure. She wants to prevent these complications. These little grandkids are the light of her life.
The grandchildren being kind of that light that guides her, and knowing the family history, being able to focus on some of these lifestyle changes, diet and exercise, that the grandkids are being raised in and modeling that behavior. That the changes that she can make in modeling these behaviors, increasing physical activity with the family, increasing meals and meal quality will have impacts on her, but she's also impacting these grandchildren that have this family history risk. From what her family has experienced and what they'll essentially inherit genetically.
Yeah, great point. And that might be able to, since that's like the most important for her, you know, maybe that could be a driving motivator for her. Sometimes I've seen kids that, you know, kind of can help their, you know, once they understand what their parents' goals are, you know, have any of you seen any of that? Once they understand, then they can help.
Allison Scott said, has she been assessed for depression, anxiety? Good thought. I have not done that yet.
Mm-hmm.
Consider that one of her future visits.
Yeah.
This is Mary Lee. I think it could be a good option depending on what her weight loss goals are, or maybe to consider a GLP-1. Maybe once weekly, it's less invasive than starting insulin, you know, wouldn't require a ton of monitoring, would help with weight loss, give her cardiovascular protection, given her hypertriglyceridemia or hyperlipidemia. And then from there, she may begin to get motivated after seeing, if she does see some weight loss, to maybe make some other changes and kind of start making diet changes. And then she could be engaged in like DSME down the line, and then kind of working on other health maintenance things, the weight loss effects from the GLP-1s and like blood sugar lowering and things like that.
And so would your plan change, you know, if you've got somebody that's really, you know, busy all the time and just doesn't have the time to cook, to exercise? I mean, I realize that's asking 10 questions in one, but that's also a big issue for her as well.
That's a great question. I just want to get back to what Mary Lee had asked and maybe ask Kathleen this too. So my you know, I think Victoza, for example, is a very good product. It seems to be well covered. We seem to have good coverage with Medicaid. It certainly does promote weight loss. Use it on some of my patients, but I was thinking more of maximizing her metformin first. Was that the approach you would take pharmacotherapeutically rather than going to a GLP-1 or SGLT2?
Well, I think eventually you know, she'll need both, if not additional therapy. So it really just depends on kind of your shared decision making with her. And someone who has a long way to go and really the motivation and ability to do a lot of things with their diet and activity is one route. I'm not 100% sure that she's there yet, but I'd certainly have that conversation with her that, as Mary Lee said, well, you know, if we do start a new medicine, you know, metformin alone won't be enough, but this new medicine may help you do all the other things that you want to do, you know, with your diet, and may provide a little bit of a jump start for you. So I guess I would also want to know, you know, how symptomatic are you? Because her A1C is pretty high. You know, is she polyuria, polydipsia? You know, is she just really weak and fatigued? And it may be that she feels bad because her glucoses are so high.
So if there's no other comments, Jim, would you mind making just a short comment about how you might start someone like that on a lifestyle program?
Yeah, you know, I think with this patient, as Dr. Boland said, we want to assess the patient's priorities for her health. But, you know, with respect to weight loss, you know, I think, again, a busy person, we don't want to overwhelm them. So we want to start with simple goals, essentially. It might be something along the lines of, you know, assessing and finding out from her, would you be able to go on walks with your grandchildren and your daughter a couple of times a week, particularly in the summer months? The weather's nice right now in the fall. You know, would you be able to do some aspects of a 4-part program that we use? It's very simple and lifestyle-based changes. And just select perhaps one of those. She could select one of those changes that she could make and work on, you know, to keep things simple and then build upon that.
The recording from today will be up on our website within the week. And if you just register on our website, a survey has been emailed to you already. Please complete this survey by tomorrow at 5 p.m. And this activity was designated for 1 AMA Category 1 CME credit. And then finally, just a note about next week. We switched the presentations from the 15th to the 24th. So on the 24th, it will be health literacy and numeracy and its impact on type 2 diabetes with Dr. Liz Beverly and Goutham Rao. And then on the 15th, we will have our impact of type 2 diabetes on minority populations clinic. So we will see you all next week. Thank you so much for joining today.
Bye, everyone.
Thank you.